All right, it is now 3 minutes past the hour, so warm welcome to the February edition of PHEMS meetups. My name is Pekka Kari, I'm the project coordinator of PHEMS working in the Helsinki University Hospital in Finland. This is the second part of our winter lineup, so we had January technical presentation about the PHEMS federated network, and today we are having a roundtable around benchmarking, how to set up an international benchmarking activity using the Paediatric Health Data Space, the infrastructure that we are building. And in our winter series, we still have one more session upcoming in March, where we will dive into our rare diseases use case. Just for today's agenda, so I will very briefly recap what PHEMS is about. Then each of our speakers will give a brief introduction from their perspective. So we have four speakers here involved, and then a roundtable discussion moderated by yours truly. The recording will then be stopped after the roundtable part, and we will engage with the audience. So you will be then can also use your mics and cameras and join for a Q&A session. And we try to stop at latest on the 4 p.m. Central European time with this session. Just as a brief recap of our project, so PHEMS was started from the need in creating data sharing opportunities in pediatric care across Europe, since many of our pediatric patient populations are very small. Rare diseases are very common and the patients are often complex, so each individual center has not sufficient numbers to conduct research, develop new therapies, and improve the patient outcomes. There's also needs for health technology assessment, type of analysis, engagement with the medtech industry or any data-hungry application like AI development. And then for the most demanding tertiary care, so many of the countries might have only 1 or 2 children's hospitals in their nation state, which means that mutual learning and benchmarking is often not possible locally, regionally, or even nationally, at least in the smaller European countries. This is why we need some sort of a data sharing arrangement cross-border in Europe in order to improve system performance, patient outcomes, quality, and efficiency. So from these needs, we drafted the PHEMS project proposal, which was then financed by the European Union Horizon Europe program and the UKRI Innovation Funding Agency, bringing together 14 partners from across Europe, total funding of 7 million euros, and we are in the final year of the PHEMS project. The project is planning to be concluded in September 2026, but the story is just beginning at that time. So we are building this activity as a permanent collaboration structure, which we call the Paediatric Health Data Space, where pediatric hospitals could become involved with and collaborate on data in benchmarking, in scientific research, in preparation and feasibility of clinical trials, and also on AI or advanced algorithms development. The PHEMS consortium consists of 6 hospitals that are members of the European Children's Hospitals Organization, ECHO, coordinated by Helsinki University Hospital, Department of Children and Adolescents, and then with technical and business partners who are supporting our work. This series of meetups has been running throughout the project, and we have the recordings available from the previous sessions on our YouTube channel, where you can tap into these resources whenever you feel that they might be handy. And with this brief introduction, then I will move forward to our speaker lineup. So we have 4 speakers, 3 active clinicians, Andrew Taylor from Great Ormond Street, Jan Willem Kuiper from Erasmus Sophia Children's Hospital, Samuel Rautava from HUS Department of Children and Adolescents. And then we have the Executive Secretary of ECHO, Ruben Diaz. And our speakers will first set the stage from their background, from their perspective for about 5 minutes on benchmarking, what has been done, what could be done, what are the needs, what are the learnings so far in building up benchmarking activities. And first I will give the floor to Andrew Taylor from GOSH. Andrew, please, you can take the control and the floor is yours.
Thank you very much, Pekka. So my task really is just to give you a quick overview. I've already spoken about what we've been trying to do, but I'll give you a very quick overview. Some general bits about benchmarking, and the benchmarking use case in the PHEMS is really around cardiology. And the idea there is around a procedure, so particularly operations as your starting point, and then it's around the time that you might spend within the intensive care. So this is a cardiac intensive care, but also can cover neonates and pediatric intensive care, and then the time that you spend on the ward. But actually there's lots of other useful information that following on from that we can also touch on. So I think just a very quick overview of why I consider particularly national or international benchmarking. And so from my perspective, it's about fostering collaboration, which is what this project really has done. And importantly, it's got to benefit patients and not necessarily organizations. It is to better measure quality of the outcomes that we have. It is to establish best in class, but that creates it from looking at who's best. It's then for about us all to learn, so that performance gap. And for us as clinicians, this is about improvement, not necessarily about ranking within the hospitals that we sit in. But, and here are the buts, we're all a little bit scared about doing this. So we have anxiety. Will we look bad? In one sense, and we've touched on why that may be in the previous slides. Are we measuring the same things? We have these discussions all the time. It is very important that we do align these out. But as Pekka has once said, what is also important here is actually if we do make improvements as an organization, whatever we're measuring, if we see change, that's actually internally very useful for individual organizations. Do we have the data and is it any good? And I think we'll have a lot of conversations about that and how you make sure that you align the data. And then importantly, how do we share that data and the governance around that, which is really a key part of what we're trying to do in PHEMS, creating some playbooks about how that happens. I think with all of the current processes that we see, often what is happening is somebody has a really good idea, and then individually each organization is often then manually curating data from whether it's an electronic patient record, patient notes, whatever it is, to often fill in into either some registry or even an Excel sheet. And that is very, very, very time consuming. And what we often see is inconsistencies in the data quality around this. It's also prone to human errors. So one of the real keys to PHEMS is actually how do we make this process more automated and how do we drive it forward such that it's not about individuals doing this and that the data is there and can be updated on a daily basis as opposed to sometimes on a yearly basis. And so the process that we've gone through, I'm not going to go through all of the list of this. This will hopefully come out in the conversation that we've had. But it's been about firstly, it's defining your data. It's then to be clinically relevant. It's about aligning that data and making sure that we're all talking around the same things with the appliances and with the approvals and compliance. And then the phase that we're at now is we can actually now generate that data, but we need to validate that data. Is the data that the PHEMS database creates now in this automated way through OMOP, is that the same as some of the data that we're sharing as organizations? And we're in that iterative phase now of this process. So the things that we focused on are number of cases, really basic in one sense, but if you get that right, you know that your data to a degree is aligned. And as Pekka alluded to, actually number of cases is super important. If we do 10 in each organization, actually that's really difficult to get outcomes or do research on. If there are 30 hospitals across Europe doing this and that's 300 cases, that's a number then that we can begin to interact with. Length of stay is a really important thing about how we manage our patients. So it may be that there are differences in our length of stay. By picking up those differences, we might be able to shorten length of stay, which is often optimal for patients, means that we in our organizations can get more patients through the beds that we've got. We want to look at complications. As one organization has a lower complication rate for a certain thing than others, what package of care do they have in place that makes that work? How can we learn from them? And the other thing that we know in pediatrics is super difficult to do, particularly in rare diseases, is what do our clinical pathways look like? So by which I mean just routine follow-up. How many times do we do an echo on a patient? How many times might we do an MRI? When's the right time to do these sorts of things? And it's interesting to begin to look now. So now that we've got this data, we can look forward as well. So you've had your operation, these are the lengths of stays, these are the complications you may have had, you've left hospital, but now this is the number of times you have an echo in the next year. Actually, if it's different between organizations, can we rationalize that so that we begin to define for our patients the correct clinical pathways, which we know is super difficult. And just finally for me, just some data that we're beginning. I'm just going to show the Great Ormond Street data because we validated it ourselves, but this is now a process that is also going on in Helsinki and Erasmus and in Barcelona. Here I've just picked, so arterial switch operation, ASD repair, surgical coarctation repair, tetralogy of Fallot repair, and heart transplant. We've then got the medium days and the range for their length of stay. That comes out. We already published that data, and as you'll see, it's incredibly similar. Incredibly, if you look at the heart transplant there, maybe there's a couple of days length and there's one patient that maybe has been picked up in a different way. And we now need to iterate that process, but we can begin to see that automatically now this data is beginning to come out for these patients, and we can begin to look at all the other things, which is hopefully what the set of conversations that we're about to have. So thank you from me, and I will now hand over to Jan. You're on mute, Jan, sorry.
I took the control. Yeah, thanks, Andrew, for your talk and highlighting the challenges we face in creating a benchmark for cardiology. I still like to take all of you to the current situation in Holland as it comes to PICU benchmarking, and convince you that it's still a good idea to pursue benchmarking, not only nationwide, but preferably European-wide or maybe worldwide. We already have the pediatric intensive care evaluation for benchmarking across the 7 university hospitals in the Netherlands who have a PICU. So all PICU patients in the Netherlands are included, and it's based on the Australia-New Zealand initiative. And I think they're probably one of the best organized quality initiatives in the world, I think. But still, we face a few very important issues. Obviously, everybody familiar with PICU care knows that we're dealing with maybe a big caseload, but if you focus on diagnosis, we don't have a lot of patients per diagnosis. Not everything we do is automated, and it's very time consuming. And in our case, we have to upload data to an external party that arranges all the data, and it's very trustworthy and well organized, but the legal arrangement that had to be made are immense, and every time we have to change 1 or 2 letters in a contract, it's a painful process that takes an amazing amount of time. So for us to see why we need larger numbers of patients across 7 university hospitals, our hospital has about 1,400 PICU admissions on ICU and a few high care patients, which is about 1/3 of all the patients that are admitted to the PICU in the Netherlands. And I guess that should be enough for general quality performance indicators like pressure sores or accidental extubations. But we once tried to get the accidental extubations down, and then you go from a low number to an even lower number. It takes a lot of time, a lot of effort, and then you basically, after such a process, think, well, did I really improve care? We did not have that feeling, because from where we started was already not that bad, and we're on the verge of thinking that a diagnosis-specific quality tool is much more relevant. But so we in our the PICE registration, we register a main diagnosis. If the reason for admission is post-operative monitoring, we not really use a diagnosis, but a surgical procedure, which makes quite sense when evaluating your process. But we currently have 425 options to register a diagnosis. And if you then consider that we only have then all of a sudden we only have 1,400 admissions, obviously a lot of diagnoses, it's not distributed equally or normally. But we only have, and then we also have 7 hospitals, only 4 hospitals if you're that perform cardiothoracic procedures. And imagine if you only have 1 hospital in your country, how can you even compare and use a proper benchmark? Our EHR supports the registration, but it would be really good if it's much more automated. And if we can get rid of an external warehouse, that would be the way to go. And that's why I think for the future, the PHEMS project created a really good basis to go from a PHEMS to a Paediatric Health Data Space with a scalable federated infrastructure where more hospitals can join, where we can have automated data extractions using a common data model, so all data is comparable across hospitals, but never leave leave your own hospital. So all the legal and data transfer issues are don't have to happen anymore. And then we would be able to create a general performance dashboard with general quality indicators, but we could also be able to create diagnosis specific dashboards. And then all of a sudden it makes sense to try to lower ventilation days across a specific diagnosis, which normally if you only consider your whole population, it doesn't make much sense. And it would be great not only to benchmark towards our few other hospitals in the Netherlands, but to a European benchmark. And then I think if we're getting there, you can go from monitoring the quality of care to really improve care. And I think I give the floor to Samuel.
Thank you very much. And thank you for really inspiring talks. I do realize I'm sort of an outsider and I'm not as familiar with PHEMS as all of you. So my presentation is really, really focused on what we could do in the future and what is my dream for the future. And what we're doing to benchmark things in the NICU right now, I think the most powerful tool for benchmarking is the Vermont-Oxford network, which is a US-based network with, I believe, 1,300 NICUs across the world, mostly from North America and Europe, who report outcomes and certain other variables from very low birth weight infants. And this is an ideal population for this sort of benchmarking because it's relatively heterogeneous and they are not so rare. In our unit, we treat maybe 130 very low birth weight infants each year. And when you multiply that by 1,000, we get a lot of data points. What we do with the Vermont-Oxford network is that we actually handpick. We have a nursing staff member who handpicks all the variables they're looking for, and we send them once a year, and we get a report once a year, and it's mostly outcomes. And we get results related to our own unit, and we see how we're doing as compared to the other units. And you can stratify by unit type and whether it's level 3, 4 to NICU, but we can only compare ourselves to the other units as to how we're doing with certain outcomes like treatment or like central line related infections. We see that we're in the top quartile or we're in the lowest quartile, but that doesn't really help us to assess why we're doing good or why we're doing badly. I think with the current data structure we have Also the possibility to collect, automatically collect these outcomes. There are problems with the quality of what we find in the data systems, but we can also collect really meaningful exposures, complicated exposures, medications, nutritional management, comorbidities. We can even collect monitor data, see how the babies are doing in our care, and naturally growth trajectories also during follow-up, MRI results and things like that. So we could in the future, in my opinion, get really powerful data of all these exposures, how they modulate the outcomes, and also what we're doing to treat these sensitive infants. We could actually get that data. I realize that's a long ways away, but I'm right now building a research project in our unit where we can really look into this. And given the large number of these babies, we can use powerful data tools to really extract important things. The other attractive populations in NICU are babies with asphyxia, hypoxic, ischemic brain damage, who are cooled, and we can look at things like hypothermia treatment and its effectiveness and factors modulating that, and the use of anti-seizure medications. We should really focus on antibiotic use in early onset sepsis, in central line infections. We could do something related to antibiotic stewardship and look at long-term outcomes and really get meaningful data about the differences between our units and how we're doing with the infections and what we might be doing wrong and right. I think that's the key. We should also find out what we're doing wrong and right. And also with the increase and our attention to parental well-being and family-centered care, we can look at parameters based on parental involvement or related to parental involvement, its barriers, other needs. I don't think we have a whole lot of data on the electronic system as of now, but we should develop things we record in the system and then could also benchmark. So I realize this is a dream, but I would be very eager to see a gradual expansion from just looking at short and long-term outcomes, which we're actually doing by hand in the Vermont-Oxford network, then to looking at complex, time-dependent exposures, their relation to the outcomes, and especially our treatment modalities. And I think the step 3 would be to create a federated real-world database for evidence-based treatment protocols, which we could then monitor using the same system. And this would also provide a nice platform for clinical research, clinical trials. We already have a structure to recording and reporting clinically relevant outcomes and modifiers. So this is my dream. I think we're far away from some of them, but I think we should start with, I think the small preterm babies are very attractive, a very attractive choice for getting started. Thank you very much.
Thank you, Samuel. And then last but not least, so giving the floor to Ruben Diaz. And I've just picked one slide for you, Ruben, and it's the ECHO members. So if you want to have it as background.
Thank you, Pekka. I must say that any of the highlights that I was thinking to sort of showcase or at least share with you, most of the previous speakers have actually touched upon. So I think this is, to me, that means that we're pretty much aligned. Maybe I give you a perspective. You know, myself and others, Jennifer, who's also present here as the organizer, we run an organization, or try to run an organization that brings together a lot of children's hospitals. And in that period of time that we've been working, we've noticed a lot of the things that you've mentioned. You know, one is the need to sort of share data because of the small cohorts that we have. Even our hospitals, the tertiary care hospitals, don't, as individual institutions, often don't accumulate enough patients in a particular area to really have a real impact on understanding the disease process, as has already been mentioned. And this brought up always the concern as to how to bring these hospitals together to sort of, try to share that data. And we quickly faced a lot of hurdles. You know, we've tried to bring together people at the quality level. We tried to bring together some people at the clinician level. And we sort of face major challenges. And I think that this is perhaps this effort that's been made here, hopefully will try to address some of those challenges. One of the challenges that I think it's been mentioned here is the fact that people collect data in different ways, and there's a distinct need to harmonize that process in order to be able to share. Once we decided that we need to share because of the lack of data, but then somehow that's been a challenge all along for organizations like ours or anybody who's trying to sort of bring data together. The other one, which I think clearly this federated approach addresses, is the GDPR and the confidentiality issues that are associated with sharing data even across institutions. Within in a given country, but certainly in a setting like ours, which is a European setting, and that has really provided hurdles, and many people have stopped, trying at this level. And then perhaps there's the other one, which already some of you have addressed, which is how do you operativize this in some way that it's actually functional and workable? And I think this is my understanding of PHEMS, as this is providing the backbone for such for an approach, for a platform that allows this process to be operativized relatively easier, in a much easier way than as others have addressed, either to pick the data manually, share it in different by different structures and different domains in order to be able to sort of compare. So I think from that perspective, the idea of PHEMS and how to provide this platform, I think is very encouraging. Some of you also mentioned the fact that for this to work, it has to really grow, and I think that's critical, is that we have to somehow make this platform quite appealing to the pediatric community, so that they can join, because that's when it gains power. And I think Samuli just brought up a lot of the issues that I wanted to bring up. This is just potentially the beginning, and should be the beginning, because this kind of platform will allow tools like AI and other and try to look at even a real world data as it's becoming more and more relevant in our care. And that, I think, should be the next step. But I think we are taking, this group is taking real steps to sort of provide a solid base for this growth. And I'm hoping that this is really materializes. And as you may know, ECHO is betting strongly that this process moves forward, but understanding that we have to sort of engage many, many more hospitals for this to happen. I want to stop here, Pekka, if you don't mind, because I think that a lot of the issues that at stake have been brought up, and I think that it would be a lot nicer to sort of open up to discussion and questions and dialogue. Mm-hmm. Thank you.
Brilliant. Thank you very much, Ruben. Thank you all for your introductory talks. And let's now have a bit of a conversation around the topic of benchmarking. So as in PHEMS, we've been building now technical setup. We're trying to build a legal framework where we could operate, which is not like tied to one specific project, but it could be used over and over again in different types of projects. And now we're entering the stage where we are showing it with some use cases, where Andrew presented one benchmarking. But how do we make it scale? Meaning that how do new hospitals join, for example, the existing ones? What are the main sort of drivers or hurdles there that we could overcome? Maybe Andrew, if you want to start elaborating that a bit. How do you see the growth of the cardiac benchmarking initiative?
So I think, as both Jan and Samuli have alluded to, the most important thing is to know the sort of data that you're after. I think the importance of this not being a manual process, even if you don't get it completely right, I think with an automated process, it's relatively easy to go back. Just suppose you wanted C-reactive protein for some reason in your outcomes, and in your first trial you didn't. In the current ways of doing it, we have to go back and ask somebody to go through all the notes again and upload it. Whereas the way I think we've approached it in PHEMS is to think of it as the cardiac database, as it were, which covers all of these entities. But that's really important. Most of us will be acquiring this data in some way. I think those who have electronic patient records are clearly in a better position to align what you acquire within your structured data, within the structured data that you're getting clinically. So that is important. And then I guess the approach that we have taken, for right or for wrong, is make sure then we harmonize. And I guess the way that we've decided to harmonize a lot of the data that we got is through OMOP. Clearly, lots of our European hospitals will have gone through a process working with the Eden project of trying to do a lot of this alignment already. For many of the rare diseases that we have, and for many of the conditions that we see in some of our use case data that we want, it's not in that OMOP form. So it's super useful. Well, it's useful overall to begin to harmonize even further that data, but you've got to have something where when you point to a patient who's had a coarctation repair, that is what everybody else is calling it in their database. So I think that's been super useful. And then throughout, for me, the two key groups of people in this is that you've got to have clearly clinical engagement and clinical involvement. But actually, as you work through this, you need somewhere between a data analyst, data scientist, data engineer, but linked in very closely with a clinician. Because actually the terms that we as clinicians understand really easily that then get represented fundamentally as a number, it's really important that we work hand in hand to make sure we understand what we're doing. Those would be some of the things just as a starting point.
Okay, thanks, Andrew. Then if you think about, starting to build a new international setup. So for example, Jan Willem, you are already clearly in some level of maturity in the Netherlands. You have a long-term existing topic. What are your thoughts that if there is now a group of who have different levels of maturity? The Finns might be on one level, and the UK might be another, and the Spaniards might be on one level. How do you handle this, that there are different starting levels? Do you have any thoughts on that?
Yeah, I don't think it's much of a problem, right? So wanting to have an entire database at once and have the whole system set up immediately perfectly is something clinicians want. Like, we treat a whole patient, not especially of pediatricians and neonatologists, we treat the whole patients, not a small part of the patients. But that's exactly not how your technical people work. Your technical people work in small sprints and small projects, iterative processes, and start small and expand. So I think, as Andrew mentioned, you need a data analyst, steward, or engineer, probably how you call it, and they will all say, yeah, let's start small. Let's start with a few parameters. And I think so from there on, it's probably a natural process. If you want to join when you're not at an as high maturity level, you will start small anyway. So I don't think it's much of a problem.
Yeah, brilliant. That's one excellent insight, and also talking to some of our clinicians who have been involved in national benchmarking. So it's also saying that there is a huge history, but still there are certain gaps that an international setup would really make a difference, and maybe starting with some of those might be really useful. How about Samuli then? You are used to already working with the Vermont Oxford international setup. So how do you see that the interaction across hospitals and clinical experts in engagement there, is that something that is easy to sort of set up and get the clinicians' attention at a needed level, both in the sort of building and then of course in the use of the benchmarking results?
Well, amongst neonatologists, we always talk about it and everybody thinks it's a great idea, and then nothing happens. I think everybody's really busy, and trying to find common protocols and benchmarking just isn't something that has really taken place. I'm always really jealous of pediatric hematologists, oncologists who have the Nordic collaboration where they create protocols for different types of leukemias, and everybody follows the protocols, and then they record the results, and a new protocol is always also a research protocol, and then they tweak them every now and then and make them more powerful or safer, the two goals. And I think that is something that is really exceptional, and that's the gold standard for the whole world for the treatment of leukemias and related conditions. And I think we as neonatologists should achieve something like that. But even with the Nordics, we meet every now and then, we talk over dinner and think it's a good idea, and then what we need is somebody to do to really start doing it, a small group of people. And I think once we have it going, I think there would be a lot of motivation, but I think there's a lot of inertia initially. I don't know if I answered your question.
Do others share that view, that it's like everybody thinks is mentally aligned, but action is missing? Is that something that you see elsewhere? Is that, or what would be needed if that alignment could be turned into action? What are your thoughts on that? Andrew, go ahead.
I mean, I think what has happened in the UK from a well, there are three data sets from a NICU perspective. There's Badgernet, there's a PICUnet, and then there's the NICU congenital cardiac database. I think what has driven some of that in the early days, and a lot of that sort of benchmarking was really around mortality, which clearly in many of our specialties is clearly there, but is much less significant than it used to be. So I think lots of these benchmarking now are looking at complications from that. I think some of this around it being mandated at a national level helps. I mean, that helps drive things. I think though the other bit, and we haven't sort of touched on this, it is very important that people feel that it's a level playing field. And you know, what we see often for potential reticence for people joining is that actually there's that internal voice that goes, yes, but our patients are always much more complex than everybody else's, and therefore our results may not be as good type way of looking at the world, which is valid in one sense. I think anything that enables people to look at their complexity and have that taken into account for the results that they then present is super useful. And so those that are getting people over that hurdle, some of that is very important. I think though what we're also seeing is some of these previously well-generated benchmarking databases are struggling, and I think it's actually how you maintain. And again, I think it comes back to this model that if people are always involved, that's high maintenance. It's not easy to do. Whereas if we can make that process, there's a lot of work that you put in the beginning, but actually once you've done that work, then actually much of this can become relatively automated. So I think that's going to be important moving forward. So it's about that first hurdle to get over can often be difficult, as somebody sort of said, but once you're over it, and if we can do it in this automated way, then I think we will begin to see some of the benefits that are really difficult for some of our patients. It's really difficult for some of our patients who have these rare diseases to understand exactly how we should see them, how we should treat them, what are the complication rates for some of these fragile services in particular, so on and so forth.
Okay, thanks. Jan Willem, any thoughts from you?
Well, I think there's definitely a need, right? Like we have our own national registry, but if I want to look at, for example, pediatric traumatic brain injury, like severe traumatic brain injury, I think we have 8 or 9 patients a year with the really serious ones, where there's a lot of mortality and morbidity, where there's a lot of things to gain. So if I compare that to our national the other hospitals in the Netherlands, like they have 3 or 4 a year, so it's not going to help anything to anyone to compare like a group of 9 with a group of 4 with a group of 3. It's not going to help you. You have to have bigger numbers. So I think for PICU there is a need if you'll be able to expand it, and I think you need a group of pediatric intensivists that see that need and are willing to start. And as we see with PHEMS and the PHDS, as soon as you start there, people see that it's working or that it has a high potential, people want to join.
Thanks. Bring Ruben into the discussion. There's been sort of mentioned things like bringing people together or facilitating or even getting a mandate to do things. How do you see the situation, and how could ECHO be somehow facilitating or pushing this forward now with the infrastructure and the work that we've done in PHEMS? You're muted.
one of the questions, concerns, ideas that I can bring up is it helps to see some benchmarking, under that structure and how it works and how fruitful it is, as simple as it may be or as sophisticated. I think if our effort here starts showing some of these results in a comparative way, that stimulates discussion, that stimulates capacity. And I guess the corollary question to that would be, how much does it take? I mean, what hospitals and groups are going to ask is that, well, I get it underway, but is it going to take me a year? Is it going to take me 2 years to get to a point where I have data? Is it something that is the PHEMS experience helping us understand how this process can be streamlined in some fashion and showcase that to some extent? I think that could be something that could help at least to engage also, the leadership of these hospitals, because I think they have a lot to gain by having these clinicians talk to each other and understanding what provides better care. But I just want, this is a kind of an answer and a question at the same time. I think that the part of the idea here is to be able to show that this is working and how is it working, and because there are a lot of registries out there, but how to apply them in an operative, clinically relevant way has been a challenge. And I think this is an effort to do so. But does this effort take so much energy that will make it hard to reach that threshold, for each case study? I'm just wondering, especially for those of you who have been involved in these cases, what is your experience and what do you foresee in the coming months how this would work? Mm-hmm.
So this comes back to what Jan Willem already mentioned, that the way of working should be more like agile, starting small. But what would be like let's say a realistic and reasonable time frame? Let's say that tomorrow there is an assignment and mandate to Samuli and the NICU team to start working with a NICU benchmarking. When should there be first minimum viable product available? Is it month, 3 months, a year, 2 years? What is the time frame which is both feasible and desirable, so that this attention would stay and focus could be maintained? Any thoughts on that? I'm just provoking a little bit your sort of. We've been doing it in PHEMS with a long, because there's lots of infrastructure readiness to be built. But let's say that you don't have to do all that, but start working. What would be the time frame, ideally, from start until you would be willing to see some results? Any thoughts on that, Jan Willem?
So I think there are a few steps that take a lot of time, and the first one is the infrastructure. And that's something you cannot do as a clinician yourself. You need your IT people involved, and I think that's could be a time-consuming process. But maybe I think most clinicians don't even know how far their cloud computing center is and what they're doing and how far they are and how much time they need to add things. The other main issue would be the standardization, but maybe some hospitals would be surprised of how far their medical informatics department is in homopizing their data lake, for example. But that's a time-consuming process, and I think, but to be honest, I don't think it has to cost a lot of time if you have the right people, the right data engineers in place. For doctors, it's not that hard just to come up with the first steps. Just make sure you get all my admissions from last year right, starting day, ending day, and link that to a diagnosis. And that would be a great start. And I don't think that has to that sounds really easy, but the steps before that are more. You need your data engineer to really come up with a good strategy to get there. Like for us, that first step was quite hard for us because our patients transfer from unit to unit. So we have to get a whole algorithm to say whether the PICU admission ended or not, because if for the electronic health record, it stops when you transfer from unit to unit. But the general idea of what you want to know and where you want to start with is not that complicated, right? There are a lot of registries already, and we don't have to invent the wheel again. But like the homopization or the standardization, you need people for that, I think.
Brilliant. Thank you. Any thoughts from Samuli or Andrew? Samuli, go ahead.
Well, thanks. Yes, this is definitely not my area of expertise, how to bring this about. But as I said, we're working on a research project with the data lake people and the machine learning, AI, IT people, and it's a fascinating journey. And it's really important to find people you can well, not speak the same language with, but with whom you can communicate, and they understand what you're saying, and I try to understand what they are saying, so we get reliable and meaningful data. And I think that process is something that could be probably, if achieved in one place, then adopted by other units. So I don't think everybody needs to invent the wheel, as you said, but this is something that I have really grown to appreciate, the fact that even though the data is in the lake, it is not guaranteed that it is something that you can use right away. So it doesn't work. The way it works is not that you just said, give me everything. You have to really know what you're looking for. And that sort of, in my opinion, a little bit defies the purpose of trying to find new things in a research project. But everything you said, I really agree with.
Brilliant. Thanks a lot, everybody. So we've now used maybe 20 minutes on this roundtable part, and maybe now I'll ask Jennifer to stop the recording and then enable also that our other participants can join the discussion. So feel free to open your camera.